people here, that's what we do.
Yeah.
All righty. Can you hear me in it? What? Huh? Yeah. Do you want me to do it right now? I don't know. Well, because we're doing the over the internet right now, so we'll just do this. All right. Welcome, everybody! Yay! Welcome to our CF retreat, and we are having a discussion today with Gina Thomas, our wonderful respiratory therapist, about pulmonary rehab, exercising with low lung function, and a variety of other things I'm sure she'll talk about. In other announcements, tonight is the talent show, so if you guys have ideas for skits and your wonderful talents, sign up with ISA, because we got to get that together. Yeah, we got to start fresh this year. So I think probably everybody wants to go around and introduce themselves so that we can all know who we are. And hi out there in internet land, we love you. So I'll start. I'm Anna, 30, CF, 8 months post-transplant, and from Sunnyvale.
I'm Isa, I'm 39, 7.5 years post-transplant from Redwood City.
Casey, I'm 28, I don't have CF, from Sunnyvale.
I'm Tom, I'm 23, I'm from Aptos, and I have CF, and I'm a double transplant recipient.
I'm Teresa Bushon, I'm 45 from Saratoga, and I'm non-CF.
Brian, 35, CF, Oakdale, California.
I'm Sarah, I'm 23, I am from the Bay Area and non-CF.
I'm Amy, I'm 20, and I have CF.
I'm Bob Wright, 46, with CF, and no transplant.
David Suhu, I work for CFRI, and I'm non-CF.
Marilyn from Stanford. Hi, my name is Swani. I work at Stanford in Bowling City today.
I'm Lisa, starting 45, 5 years post-transplant. I live in Petaluma, California.
Paige, 16, non-CF. She's my mom.
Hi, Eric Martin, 35, have CF, and I live in East Bay.
And then Jessica walked in.
Jessica, 35, no CF, live in the South Bay.
Good.
Okay. Well, it's my pleasure to be here, and it's nice to see some of my friends again, because it's always nice to see how you guys are doing, and I messages from the rest of my team that I work with. They're always happy to see you, and look forward to hearing how you're doing. So, because when patients come into pulmonary rehab, usually there is a continuum of seeing the patient over a long period of time, and we really get to know you, and we're there to support you and to help you to achieve your goals and to live a good life, live a high life. Okay? Because that's what you guys are doing today, right? CFI.
Yeah.
So some of the stuff I'm going to talk to you about is going to be just a reinforcement of what you already know, but just to get back to why you're doing what you're doing, because exercise is always, taking something that is stationary and putting it into something that is not. And there's always the laws of physics. Oh, you said that because of the mic. So sort of a law of physics that a moving object keeps moving, and an object that is not moving isn't. So we want to keep moving because it's extremely important. And why is it important? Oh, these handouts I had, we're going to be kind of going from one to another. So if I tell you which one, you can pick it up. But why are we exercising? Why you exercise is the same reason why I would exercise. It doesn't matter if you don't have CF or you do have CF. The benefits seem to carry over, and that's been proven, for many, many years. By the way, I've been a respiratory therapist for 37 years. So my knowledge base of what we knew before and what we know now and how we came to treat pulmonary disease and CF is totally different from how we view CF and treatment of pulmonary disease in general. And it really hadn't been till the last 5 years if you can imagine that really evidence-based guidelines came across as to why we use pulmonary rehab to treat lung disease. So prior to that, there really wasn't really good evidence to show why we did it. There is overwhelming evidence now. And in fact, it's considered the standard of care to give patients with pulmonary disease pulmonary rehab. Way different than what it was before. And I think you know that just how we treat CF. Well, some of you aren't even 37 years old, so you wouldn't even know. But trust me, it is not what it was. When I came up as a young respiratory therapist, taking care of very young people that had CF, it's just not even in the same category. So, some of the things that we know that exercise does for us, it increases muscle mass, okay? It increases muscle strength. It helps with blood pressure. It helps with blood sugar control, which is very important, I think, for you, for patients with CF, because some of you are diabetic, and it really does help to manage blood sugars better. It helps to improve sleep, and yes, when you have chronically ill, and there's lots of other things that go on with being chronically ill, sleep can be disrupted, and it can be disrupted for lots of other things. Some of the drugs you're on. You know, when you get an infection, sometimes you're on antibiotics, and then, yes, so my friend, we get the P pill, we get the prednisone pill, and we know that that disrupts sleep and makes it more difficult to sleep. And I recently just had to go on a course of prednisone for a week, and if you think I talk a lot now, you should have seen that. And it happened because I got stung multiply by a wasp. That was not good. And the prednisone worked like a charm. So, like I said, I did disrupt my sleep quite a bit. Wasn't able to sleep. But it sure worked on that wasp. It also is known to counteract osteoporosis. And if we do have to remain on long-term steroids, yes, there is a chance for developing osteoporosis. There's a chance for developing that anyway, you know, depending upon your genetics and your gender and what have you. But it does seem to help that. And there have been a couple of small studies that show, and these were in post-transplant patients, that it improved bone to the lumbar spine, which is very important because you guys are at risk. So even pre and post, there's been a little bit of evidence, and not enough by any stretch of the imagination, to show the benefits of doing pulmonary rehabilitation pre and post-transplant. But we do have a lot of good data to show about pulmonary rehab pre and post-surgery in patients with COPD, chronic obstructive pulmonary disease. Some people say that CF is in that category. It's different, much different, because you have many other issues with CF than you do just with chronic obstructive pulmonary disease. But there's a lot of good, a bulk of evidence to show that that is very, very important, okay? Some of the other things it does, it increases metabolism. I like to mention that because if you have not been exercising and you begin to exercise more, you are going to be burning more calories. You guys already have to stuff calories in. So you need to realize you're going to actually need to supplement even more so you don't prevent weight loss and you don't actually cause reduction in muscle mass. You know, counterintuitively what you should be doing. So make sure you remember that. The other thing too is in general, patients with obstructive disease have a greater work of breathing than I do or any other normal person, which means you burn more calories. Breathing, just sitting there, you breathe more calories every day than I do. So that also, you have to take that into account, that you are in fact losing calories that way. Also, just by the work of breathing, you lose water. That's one of the biggest ways we cool ourselves. We cool ourselves by sweating, and we cool ourselves by breathing. So if your respiratory rate, your normal respiratory rate, is greater than a normal person's, which is probably in excess of 10 per minute, you're losing more water. So you do have to pay more attention to your nutrition and your fluid intake if you're exercising, because you're going to be using more fluid and more calories. All right, what kind of exercise is good? And what I'm going to talk to you about in this part, it says the basics and how we came up with the basics. Well, how do we decide this is what's good for you? Well, as it turns out, it looks like pretty much what's good for you guys is good for everybody else. But there was a very important study, and I'm going to refer to that a couple times. It's called the NET trial. And the NET trial was the National emphysema therapy trial. And they said, I've got that emphysema. But what we learned from there can cross over into many people that have lung problems. And what this trial was there was a surgery that's done, it's still done, it's called lung volume reduction surgery. And what happens in this surgery is they remove parts of both lungs. Wow, you go, wait a minute, I'm not breathing already, why do you want to take some of the tissue out? Well, in emphysema and in some other kinds of chronic obstructive disease, you have areas of the lungs that are no longer working, and they're hyperinflated. In other words, there's air there, but there's no vascular or capillaries around it, so there's no transfer of oxygen, and also this inflation also pushes on the good lung tissue, sort of like blisters inside the lungs. They're called bulli. And sometimes patients with CF will have some bulli. You'll see them on CAT scan, generally. So, that's true. Okay.
I just said that.
Okay. So what they did in this study, and what happened is when this first came out, there was unbelievable good success. Patients that had emphysema were able to exercise, their lung volumes improved, everything was doing great. So unfortunately what happens is the surgery gets done a lot. And there were probably people that are not properly trained to be doing this surgery, and actually what happened was the mortality rate for this surgery was quite high. And in general, a lot of patients that have COPD are in an older age category, and these were Medicare recipients. Well, Medicare, that was the big red flag. What is going on? We are paying for a service and a surgery that has extremely high mortality. We aren't going to pay for this. Well, there were the most powerful doctors, just so you know, in the pecking order of doctorness, it's the surgeons, okay? I'm going to say it right now. And the surgeons actually got together and said, you know, we have seen how this works. We want to bring this forth. We're going to prove to you this surgery is efficacious and effective. So what happened was that NIH and Medicare, CMS, sponsored a study. And you're never going to see this again. I don't think this will ever happen in our history. And they actually funded a study to look at whether or not this was effective. And they divided everybody up. So one part was going to get the surgery. One part was not going to get the surgery. But everybody was going to get pulmonary rehab, pre and post randomization. This is huge for pulmonary rehab because we were going to be able to prove what it did. And in the end, everybody that got the pulmonary rehab improved. Some of the people that had the surgery improved, but not all of them. And so what came of it was a small group of patients would benefit from this surgery. And it is still done. But what came out of that, pulmonary rehab helped everybody. Yes. Yay! And we were actually at Sequoia, a satellite for the pulmonary rehab for the study, the national study. And so we saw these patients. So we saw them when they were randomized. We saw them pre, we saw them after. So very important, and a lot of what I'm going to tell you is what this group of experts got together and decided, this is how we want you to perform this pulmonary rehab. It has to be standardized because we can't let the person in Atlanta do it like you're doing it here because the data is going to be skewed. So everyone had to do it the same exact way. And this is what they came up with. This is what they decided was important for you, what would be helpful. The very first thing is, no surprise here. They want you to be doing some kind of aerobic exercise that involved the lower extremities, the large muscles. And that meant they wanted these patients, and they were quite sick, to do aerobic exercise 5 days a week, period. They came to us twice a week. They had to do an additional minimum 3 days a week. And that is pretty much the goal right now. It needed to be 20 to 30 minutes. Okay, in the beginning, we had patients that could not do 20 to 30 minutes. They had to work up to that, but that's was the goal. And they had to warm up and cool down. We had to make them warm up and they had to cool down. It was very, very structured. In fact, I had to make sure I did this patient even maybe differently than the ones that weren't enrolled in the study to make sure it was the exact same way. Then the other thing they wanted to do, they wanted 5 days a week. They got to do flexibility. They got to stretch. No one wants to stretch, but I think we all know that these respiratory muscles, okay, and your respiratory muscles, to give you another little idea again, you have your neck muscle here, you have your shoulder muscle, your neck muscle, you have your rib muscles, you have your diaphragm. Okay, and to some degrees we know also that the abdominal muscles play a role, and maybe even the back muscles in breathing. They get tight, don't they? And they spasm. So stretching is very important because there are very few exercises that we do, if you think about it, that mobilize these muscles and improve flexibility of the rib cage. Well, if you're more flexible in your rib cage, you can expand your lungs better, can't you? So it's something that I really feel is very important, but maybe doesn't get focused on very much. So these kinds of stretching exercises are very important. Does anyone do yoga?
Yesterday.
Me too.
We all did.
We all did it yesterday.
We love the yoga. We love the yoga. And yoga is, excellent for flexibility. And as you know, they focus on breathing. They focus on breathing with the movement. So there's different styles of yoga, as we know. I mean, I don't recommend that Burkham hot yoga thingy for you. Okay, I did that one time accidentally. Everything I do is accidentally. But I'm in the hot yoga? Yes, you are, Gina. Okay. That wasn't for me, but there's a lot of other styles of yoga. Ashtanga is the power yoga. There's vinyasa, which is more the flow yoga. That's really good because they really work in the breathing. They wanted them to do that 5 days a week. So every time they did their aerobic exercise, they had to stretch. And when they actually did the stretches in this group, we had to have them hold the stretches for a minimum of 15 seconds up to 30 seconds. And that's a lot longer than most of us ever do. They also wanted them to do something that's very interesting, upper extremity endurance exercises, unsupported. Unsupported. And we're going to do some of those. But to give you an example is if you have weights and you're doing this movement, or if you're on a machine, that's supported. Unsupported is when your arms are out and they don't really come down. They stay in this position, or they're moving, okay? They felt that was very helpful to train the respiratory muscles, because when you do activities of daily living, when you're reaching, do people get breathless sometimes when they're doing activities of daily living, like showering, bathing, lifting, carrying? Okay, well, if you think about it, you are using the same muscles that you use to breathe with. So they're sort of getting the double workout. Okay? So they asked them to do this 3 days a week, 10 to 15 minutes. It's hard to do a day, okay? And then lastly, things that we understand about is strength training 3 days a week. They wanted them to do 1 to 2 sets, 10 repetitions a day, and they had a set group of exercises they wanted them to do. And I included those for you. This is the one that they came up with, the net. And this was done nationwide. And when I see articles in magazines now, and I see articles, in the newspaper, and they show just these 10 strength exercises you should be doing, it's almost always the ones we've been doing all along. Okay? Some for the upper body, some for the lower body. Now I want to talk a little bit about the differences between when patients with CF exercise and patients that don't have CF exercise. And a lot of that's going to do with your breathing. Okay? And some of the things you should think about is, and no one here is using oxygen, I see that, but I do want to talk about that. Sometimes I know that if you've had an exacerbation, that means a flare-up of your symptoms, you've been hospitalized, sometimes these hospitalizations are pretty lengthy. So when you get out of the hospital, you're deconditioned. Sometimes, every once in a while, someone needs to go on oxygen for a short period of time. That's not unusual. In the olden days, when you used to hang out and you stayed at that hospital for a whole month, maybe your oxygenation improved while you were there. But now you're getting kicked out, and rightfully so, because you want to be out of the hospital as soon as you possibly can. And so your oxygenation may not have recovered back to where your baseline was, and you may need some oxygen for a little while. Use it. Okay? Usually, if we see that your oxygen levels are low, we may not want to reassess that and decide you don't need it for several weeks after that period of time. All right? And when we really know your oxygen is low, a lot of times we will, or if there's been other issues where your heart's been affected because of low oxygen levels, we may wait several months before you want to discontinue that oxygen use. And this can happen off and on in the course of your lifetime. Okay? This is not unusual to see this. So if you need oxygen, use it as prescribed. Who here has an oximeter, finger ox? Of course you have the jewelry. Everyone must have the jewelry. Okay, and in the olden days, I have to tell you, one of the first oximeters that were ever made for hospitals, was made by Hewlett-Packard here in Palo Alto, and it was actually part of development from the space program from NASA, because we had to be able to measure the oxygen up in the space, right? You can't.
You can carry it.
Oh. Thank you. Is it on though? Is it on? Oh, okay. All right, so because of the space program, we needed to be able to measure oxygen levels of the astronauts up there because they're up in no oxygen atmosphere. And one of the very first oximeters, it was highly accurate. It was on a stand, and it was this big, about that high. And it had a fiber optic little cord, and we took it and we screwed it down onto your ear. Not screwed, into the ear, but onto the ear, and then had a flap that you had to wear.
Oh, God.
Do you remember that? It was highly accurate, and of course it was extremely expensive. And so of course Hewlett-Packard stopped making that. But because of this, we ended up getting to, oh my God, a finger ox for $40. Now those first finger oxes when they came out, made by Nonan, $500. Oh yeah. And now you can get them for $40. And are they pretty accurate? They're pretty accurate, but you have to understand, the kinds we have in the hospital are a lot different. They have, most of those have what we call motion artifact in them. Okay, so that if you are moving or something's happening, it can keep a steady pulsatile flow and pick up the read. If you're walking and you have the finger ox, it's not accurate. Okay, it needs to be stationary, unless you got one of those fancy ones, okay? So I have that all the time. Patients are walking, oh my God, I went to 75. What, did you feel like it was 75? No. Oh, well, it probably wasn't, okay? So you need to, it has to be, most of them have to be stationary. And they are very sensitive to light. They're sensitive to nail polish colors. And all of those and several other things, okay? And if you are really interested in oximetry, I can give you there's an excellent downloadable pamphlet. It's called The Patient's Guide to Oximetry, and it's by Dr. Thomas Petty. And I really recommend that. It's an excellent pamphlet. It really explains what oximetry is, how it works, how you can look at your own oxygen levels, how you can titrate up, titrate down. Titrating is referring to increasing the liter flow, decreasing the liter flow. Okay? So I recommend that. It's free. You can just get on that. And Dr. Petty is the father of pulmonary rehab. He recently passed away, and he actually, in his later years, he was in his late 80s, he developed pulmonary fibrosis, and he was on oxygen himself. The coolest guy ever. Very cool. Very cool. Just a little tear when I think about it. But anyway. So use your oxygen, it's important. Now, what is not enough? Well, this is not like bragging rights. Well, I once got down to 65. Okay, there's no bragging rights in oxygen level. Okay, what is safe? What do we consider safe? What do we do? What do we change when you're in the hospital? Anything that is 88% or lower, we feel you need oxygen. Okay. That's it. I'm not going to change my mind about that. Nothing's going to happen. Because guess what? That was also determined from a very large study called the NOT study, the Nocturnal Oxygen Therapy Trial. And from that we learned what was enough and what was not enough. And that is how Medicare decides to give you oxygen or not. Okay? In order to qualify under the Medicare benefit to get oxygen, your oxygen level has to be 88% or less during sleep, exercise, or rest. Unfortunately, you could get it if it was 89%, but you'd also have to have right-sided heart failure, which is not a great idea. So that is set in stone. That ain't going to change. And so that's really how we know. In the hospital, though, I have to be truthful. If we had a person that came with cardiac condition, we aren't going to let them go down to 88%. We're going to keep them way above 90% because the heart is a very big user of oxygen. What are the organs that use a lot of oxygen? Your lungs? Okay? So the brain and the heart. So these are the things that oxygen protects, and we know this. We know this, that it can help prevent right-sided heart failure and pulmonary hypertension. So oxygen therapy is extremely valuable. And a matter of fact, it's a drug. can only be prescribed by a physician, and it's the only drug we know that prolongs life. So it's really good. So if you do need oxygen, consider it, please. And 88% is where we usually like to keep. Do my patients ever drop down lower than that? Yes, usually I don't usually see it too much in the CF patients, but we have some patients that we see on a regular basis. Patients with pulmonary fibrosis, their oxygen needs are quite dramatic. They need a lot of oxygen. And they do typically drop down to lower levels, but we have to be very careful when we're monitoring them. Now, I'm going to talk to you about something else that's very interesting about CF, and that would be for CF, it would be for COPD, it could even be in asthma, but not as often. There's something called hyperdynamic inflation. And this is very important in exercise. And this has been looked at most specifically in chronic obstructive pulmonary disease. But who here uses inhalers? Or nebulizers? So you know, all that. We all do. Bronchodilators. What do? Thank you. That's right.
Can you repeat whatever?
Oh, what do bronchodilators do? They dilate the airways. That is exactly what they do. Okay? Now, in dynamic hyperinflation, what happens is because naturally what happens when you take a breath of air in, your bronchi dilate and they lengthen. When you exhale out, they shorten and they narrow slightly. However, in obstructive disease, they can collapse, or they can narrow down to a very low or very, very narrow airway, or they could be narrowed in the first place, and they could be narrowed for other reasons. But that in turn then can reduce the amount of air you can get out. So what happens is you get air trapping. And you hear that a lot. I think you guys have heard that. Oh, you had a lot of air in your lungs, or you have air trapping, or what have you. And this is a common thing we say. We can see it on your chest x-ray. We can see it on CAT scan. We can see it on in the pulmonary function tests. Okay? We can see what they call air trapping. So what relieves air trapping? Bronchodilators. Okay. Bronchodilators relieve air trapping, as well as oxygen. Now, how does oxygen do that? Well, if you're breathing fast and you're already having trouble getting the air out, you do what we call stacking. And more trapped air remains in the lungs until where you have a very small area to expand the lungs. Now that is really hard to exercise at that level. It's really hard. And that usually is what elicits this feeling of shortness of breath. Or you feel like you can't get a breath of air in. You feel that? I feel like I can't get it, I'm locked. I can't get a breath of air in. Well, you can't get the breath of air in because really your lungs are already full. Okay? So bronchodilators relieve obstruction and therefore reduce that hyperdynamic inflation. As well as oxygen. Now oxygen, how that works is that it slows your respiratory rate down. Okay, so if it slows your respiratory rate down, you have less air trapping. So those are the two strategies we use to prevent this hyperdynamic inflation is bronchodilators and oxygen therapy. And there are some people that feel that oxygen therapy, even in patients that we call normoxic, means they don't have low oxygen levels, may improve their exercise endurance. Unfortunately, the studies are very small, like they're usually in groups of 10 or 8. It's very difficult to fool a person if they're getting oxygen or not getting oxygen. And when you do a controlled study, and you know, in science it's got to be controlled. You know, no one wants to believe anything that's not. I guess that's good, you know. And so, you know, some of the studies, they actually had to have the person use compressed air. Others of them used oxygen. The person who was exercising, the person couldn't know if it was compressed air or oxygen. The other person was in another room that actually turned on the dial, the whole 9 yards. It's complicated, which is why it doesn't get done. The other thing is there's not any money in oxygen. Used to be. Oh, man, a long time ago. Made a lot of money from being able to deliver oxygen, but now it's just really I think you make more money having a Starbucks thing, okay? So there's not much money being made in oxygen, so is there going to be a whole lot of studies? No? Okay. All right. So So the other thing is and when you do that, I have to tell you, and who here also has been told they have a little asthma? Not uncommon, okay? Twitchy airways. So, yeah, that's what they call them. We call them twitchy airways. So what is going to have to happen for you is you're going to need to time it how it works best for you. Some patients, immediately 15 minutes, they feel their bronchodilation, they're on their way. Other patients, it might be more like 30 minutes. I've even had some patients an hour. So depending upon the bronchodilator you're using, you have your quick acting. That would be mostly like your albuterol. Brand names would be Ventolin, Proventil. But a lot of you are also just using long acting, and they take longer to kick in. Okay, so like things like Fordil, a little quicker, like maybe about 10 minutes. But things like Ceravent, long time, 30 minutes to an hour to kick in. So you need to know your bronchodilator if you're going to use this as a strategy. You need to know what you're putting in there, all right? And what is its onset of action? When does it start for you, okay? We usually just tell patients they're going to use their rescue drug prior to exercise. That's what they're going to use. All right. Okay, mucus. Yeah, mucus obstructs, okay? And my saying is mucus makes mucus. And I want someone to cross-stitch that for me on a pillow one day. But mucus makes mucus because mucus in itself is composed of protein, sugar, and water, okay? Those are cells, okay? White cells are also in there. And white cells have an inflammatory process, okay? So when a lot of mucus is sitting down there, there's a lot of inflammatory cells down there, and that tends to irritate the airway even more. So that's why bronchial hygiene, I'm preaching to the choir here for sure, is important. But, I think some patients know that when they start to exercise, immobilize secretions, doesn't it? And it's a heck of a lot more fun than that vest or that a cappella or any of those other things. Or some people do like getting the percussion. But any of those things. So bronchial hygiene is important. You want to clear your airways. You might also find out that you're able to clear your airways while you're exercising. All right? So do that before. And then the other basic things you need to remind yourself is, don't exercise on super hot days. Don't exercise on super cold days. It really would be best for you to be indoors, especially those of you that have twitchy airways or asthma, because cold air is a major trigger for that. So if you really have to be outdoors using a warming mask or a silk scarf, I know that a lot of the post-transplant patients use the techno mask, but I want to tell you that it may not work for you because there's a lot of resistance in that mask. And those masks were never meant for patients that had a lot of restriction. You may be able to tolerate, you may not. You're going to have to try it. There's no way to know it. In fact, in the hospital, everyone has to be fit tested because, we're exposed to organisms that may be airborne that could be potentially, contagious to us. And everyone has to go through this process called a fit test. And we've had some people that work in the hospital that have asthma, and it's very difficult for them to get fit tested, to pass the fit test, or they may not. And we have to decide what we're going to do or how they're going to function in the hospital because they can't tolerate the mask. No one likes wearing the mask. Trust me. But if that's the case, and you think you can tolerate I know a lot of the post-transplant patients, they are able to eventually adapt to that. It's hard in the beginning, though. Is that true? Yeah. There's a lot of resistance. Okay. And breathing patterns. Use your pursed lip breathing when you're exercising. Okay. I use pursed lip breathing if I'm really working out hard, or I am going up, especially hills, I get into that breathing pattern. Okay, so pursed lip breathing is extremely helpful, and it helps to reduce some of the hyperinflation. So it's important to do that when you're exercising.
Can you
demonstrate? Sure. Okay, so pursed lip breathing can be used in conjunction with diaphragmatic breathing, or it can be used on its own. Okay, and basically what you're going to do, you're going to exhale out 2 to 3 times longer than you inhale in. Okay. So most people that have an inspiratory-expiratory ratio of 1 to 2. Okay, and this one we're going to prolong it, so it's going to be like a 1 to 3. So you breathe in, and you exhale out through your lips, just like you have a candle here, and you want it to flicker. but you don't want it to go out. So it's not this. You see a lot of runners doing this. They don't know why they're doing it. Okay, but they're creating a back pressure and they're opening up their airway. Okay, but in pursed-lip breathing, it's going to be prolonged. So it's going to be, because we don't want to collapse our airway. Okay, and really a forcible exhalation can do that. You know, that's why you have to be careful when you're coughing or other things you're doing. I know you guys all have your techniques of how you learn how to do it. I just go the other way. I don't watch you, okay? Because sometimes I'm thinking, oh, I hope they don't pass out. Because some of you have some really interesting techniques. But make sure that when you're doing the pursed-lip breathing, it's steady. Okay? So in through your nose. Why do we want to use our nose? Filter, hydration. Our lungs hate dry air. They hate it. And in fact, that's one of the reasons why patients get what they call exercise-induced asthma, is drying of the airway. That's what we know. So that's why the biggest place where you see it happening on the soccer field with the little kids, they're running outdoors. You don't see it swimming so much. That's why all the asthmatic kids are in the swimming pool. Because when they're swimming, they're right here, they lift up, there's humidity here with the water level. So swimming is always one of these things that have been, oh, they've got asthma, put them in the pool. Okay? We have better drugs now, so I think you can run and do soccer now. Okay? All right. Let's see, what else? Make sure you're drinking enough fluids, make sure you've eaten. And thank you, and Anna, as she would. She gave me all these little lists of things. Make sure you cover this, Gina. Make sure you cover this. Anyway, if you are diabetic, if you are using insulin and you haven't been exercising, you need to take a blood sugar before you start. You need to take a blood sugar after. It can be shocking what can happen. Okay? And you say, I've never had low blood sugar. You could have low blood sugar. All right? So you do need to do that. Okay? Because we've had a couple of big surprises in rehab. To be truthful, that we did not expect it, and they dropped significantly. They came in, their blood sugars were 130. They exercised with us, their blood sugar was 60. So it can happen, and I've really learned. And let's see, what was the other thing I wanted to tell you?
I have a question.
Yes, ma'am.
Please repeat the question when people ask.
Okay.
Is there any kind of formula on how much people burn in glucose? Or
No.
is it individual?
No. No. Is there any formula you could use if you knew what your starting blood sugar was that you could determine? No, there's just too many factors, because you have to remember too, what was the substrate? What was the actual food that they ingested before? And what is the combination of that? I think we all know about that from how people now are, combining their sugars or not combining their kinds of sugars, their simple sugars to their complex, and no. And like I said, we asked the person what the meal was that they came in and they had. It included a protein, it included a carbohydrate, usually it included Starbucks. I don't know what. and it didn't seem to follow. And there are other factors that affect blood sugars, too. Infection is one that affects blood sugars. Even your drugs you're on could be affecting blood sugars. So no, boy, that'd be nice. But, I'm going to pose that, and if I get any other different answer than that, Anna, I'll talk to my expert, Julie, in the DTC, and see if there is anything, because we always call upon our DTC, our Diabetic Treatment Center, to help us with these questions, because they're so good. They're so good. All right. Now, who here knows how to count their pulse? We don't have to do that then? Okay. Are you really good at it? Okay. We'll move on to the next part.
Did everyone on the web wave their hand?
Okay. Okay, so one of the things I want to give you an idea about is your target heart rate. Target heart rate, I usually use that mostly just so you don't over-exert yourself, okay? But we have to remember that resting heart rate is a big range. 60 to 100 is considered a normal heart rate. Okay? That's big. 60 to 100. To 100. It's not, it's not considered tachycardia until you go above 100. Tachycardia means fast heart rate. Bradycardia, less than 60. Okay? And that's sort of, that's a standard. Now, you guys may have faster than normal resting heart rates. Okay, and why is that? What do bronchodilators do? Yeah, they're adrenaline-like. Okay, so you may have faster than normal heart rates. Also, work of breathing, what do you think that does? And what do you think a low oxygen level can do? Okay, so all those things can make your resting heart rate a little bit more than other individuals. So you kind of have to know what is your normal heart rate. But on this, it talks about calculating your target heart rate. What is going to give you a good guideline here is, unless you have a cardiac condition, and you know you have a cardiac condition, your physicians talk to you about that, then you really need to talk to them about your guidelines. But we usually use this one. We use it in cardiac. We use it in pulmonary. It's T20 minus your age. That's your maximum heart rate. You don't want to go above that. And the reason for that is you can't pump enough blood around. Okay? You actually decrease your cardiac output, how much you pump out each time. All right? So that's counterintuitive there. So then you take your max heart rate and you multiply it by 70%, and that gives you your low target. That's kind of what we want you to start to exercise in. And then you take your maximum heart rate and you multiply by 85%, and that's about as much as we want you to go. Yes?
Can you quickly remind us how to calculate our maximum heart rate? Is it not, I mean, for those on the web who don't have the handout?
Oh, take 220 minus your age, that's your max heart rate. Then you take your max heart rate times 70%, that's your low target. You take your max heart rate times 85%, and that's your high target, and that's your zone. Your low and your high. Okay? For the post-transplant patients, they gave us guidelines, what they wanted us to do with you guys. So they told us, we had to sit on you, a couple of you, but they didn't want your heart rate going up any more than 150. and they didn't want your oxygen levels going down below 90. And they gave us blood pressures as well. Were they allowing us to as a guideline? And on this, people often ask, how hard am I supposed to be exercising? In pulmonary disease, in cardiac, we use that heart rate all the time. We don't use it as much in respiratory. And also, too, sometimes you're on some medicines that may lower heart rate and blood pressure, and you're not going to get up into those target ranges. You're just not. Okay, it's just not going to happen because these medicines are keeping your heart rate down. But we use the dyspnea scale, and we use the Borg, what's called perceived exertion scale. And in this particular one here, it talks about 0 to 10, and I don't like the word severe, and there's different words they use. I like to use hard. So 0 is, at this moment in time, you're not breathless at all. 10 is the most breathless you've ever been. Okay? So there's a big range in there. We usually have our patients exercise anywhere between 3 and 4, and it says somewhat severe, but really it's somewhat hard. On the perceived exertion, they use that a lot more in cardiac because they usually don't get short of breath. They usually get limited by their heart rate, or unfortunately maybe by chest pain. Okay, whereas patients with lung disease usually get limited by their breathing before they get limited by the other things. Okay? And that one you're usually having you saying it falls over to somewhat hard or hard. You're working. Okay, it should be the same for you as it is for me. I should feel like I'm doing something when I'm exercising. And if you want a reality check, this last little part here, the breakdown rate, this is the way it is, folks. There's just no way around it. If you haven't been exercising and after about 2 weeks, you've already really declined by 15-20% of what you're able to do. That's why exercise is really important. Even if you are hospitalized, of course, there are going to be guidelines for that. But if you can at least get up, sitting in the chair, believe it or not, that's very important. Even standing is important. If you can walk the halls, if you can't, you might even ask, if you have to be in there, ask if the doctor can order, the doctor needs to do this, that you can have some dumbbells in the room. and you could do some work while you're in the room. You know, I know you guys get very limited, you know, in your infusions, what's going on. Some of these infusions are very long, so it's hard to be able to go to a gym and come back, and the nurse is all on a tiz because you didn't get your infusion, and, you know, that has to be timed. But sometimes, you know, they do allow you to go to, if there is a gym there. It depends, because it depends on what you've been colonized with. They can't always allow you to be with other patients. Sometimes at our hospital, we've had them bring in stationary bikes to the room. I find that to be very helpful because a stationary bike, you can really work your lower extremity muscles without maybe taxing your respiratory muscles as much. Okay, anything you do seated is nowhere near as hard as free walking. Nowhere near. Even on a treadmill, it's nowhere near as hard as free walking.
I just want to say, where you're holding the mic this far away is really good. Don't hold it too close.
Oh, because I'm spitting?
No, it's just starting a little bit. Yeah,
Okay, all right.
that's perfect. Just hold it kind of low.
Okay.
Thank you.
Thanks, Eric.
Appreciate it.
Okay. I feel so special. Okay. So let's, at this point, well, first of all, let's open it up to some questions.
So do you have any idea, framework of how the detraining calendar changes with added Solumedrol or added prednisone use?
No, but we already know that prednisone melts muscle. Oh, excuse me. Do we, as far as detraining goes, do we know when you're on steroids if it's worse or what, or if it accelerates it? We don't know that it accelerates it, but we know that prolonged steroid use, you know, leads to muscle dysfunction. Okay. Actually, prolonged chronic illnesses lead to muscle dysfunction. So there's no way to predict that too. And you know, there's some patients that tolerate steroids very well and don't seem to be affected one way or the other. And you know, just like we all know, our you know, the genes are the genes, and we don't all react the same way to medications. Even the doctors say, "Oh, it should work for you." Well, it didn't. Okay, because you know, even whenever drugs get released, you know, even if it was a large study, it's not that large of a study. You know, and so we always have to remember we are all very, very individual. No, there's no way to know that. And there's going to be some patients, you know, the one time you're on steroids, you didn't seem to be bothered by it. The next time you were. Has anyone experienced that? I don't think that when you take the prednisone, you can predict that you're going to react the same exact way. Because I don't think, at least it's been my experience, that patients don't necessarily do that. One time it worked like a charm. The next time you took it, you thought, I might as well have been taking a sugar pill. It didn't seem to help. So, sure helped that wasp bite, though. Or sting, excuse me, not a bite.
Is the breakdown rate that you have for lung disease specifically for anyone?
Oh, anyone. Thank you. This is for anyone. Okay, like if I stopped exercising, this is what would happen. Okay. Okay, and also too, you know, we know that for functionality, it's very important to be able to use your lower body, but using your upper body is also very important, and training your upper body is also very important. So, because these are your breathing muscles. These are not your breathing muscles. So, upper body training is extremely important in patients with lung problems. All right? Now, do we want to do some exercises?
Open it up to any other questions?
Oh, yeah, absolutely.
Anyone from the audience?
You look really excited to exercise.
Asking a lot of questions.
I have a question then.
Yes.
A couple things, actually. First, like the addition of oxygen if you're exercising, at what point does that increase your CO2? Because that's the thing I've heard before.
Okay. Okay. When you're using oxygen, does that increase your CO2, your carbon dioxide level? Well, it's been known that there is a very, very, very small amount of patients that that are going to be sensitive to this problem. Not the majority at all. However, you have to remember, when you're exercising, what's happening? Are you producing more CO2? Yeah, by the process of the exercise. You're taking in oxygen, you're burning fuel to feed the muscles, you throw up your carbon dioxide level. And that was a really big concern in the NET trial. We were concerned, we were taking patients that we knew had elevated CO2s and were making them exercise, and we knew that it was going to drive their carbon dioxide level up. Were they going to be able to get rid of this carbon dioxide? Well, there was no way for us to really know if it happened or it didn't happen, because we would have to be able to collect their gases while they were exercising to know this. We generally don't worry about it. We really feel that most of the patients are going to be able to tolerate that, especially patients that are well enough to be carrying out some activities daily, and they're walking and what have you. They usually are going to be able to be okay. So we're not too concerned about it. Like I said, there is a situation where there are patients that if you give them too much oxygen, they will actually reduce their respiratory rate, we told you about that, and they will actually increase their carbon dioxide levels. This is usually in a pretty compromised patient. And usually the doctor knows what your carbon dioxide levels are, and they'll tell you. They say, you have really elevated carbon dioxide level, we want to keep you, and they will even, some of these patients, they will say keep their oxygen levels around 88% or 87% when you're exercising them, because we suspect that we're driving up the carbon dioxide level. And they usually have to remain on low flow oxygen. We don't use high flow. But I will tell you one thing, and this is long been a controversy anyway. I will tell you what will kill you: low oxygen level. Okay? Will high carbon dioxide levels kill you? Maybe, maybe not. We tolerate it very well, and we compensate very well. We don't compensate so well for not having enough oxygen. So in respiratory, we say always oxygenate the patient. If you don't oxygenate the patient, it really won't matter about their carbon dioxide level. So, and there are ways we can deal with carbon dioxide level in the hospital. We generally feel that most patients will be okay if they're able to carry out these activities. There's, other things that raise your carbon dioxide level. High, simple sugars. That is the byproduct. Okay, when you burn fat, Pulmocare. Who's over here, Abbott? They got the Pulmocare over there? Okay. Okay, Pulmocare. Well, Pulmocare is very high in fat, because it actually, when you burn fat, you don't produce as much carbon dioxide, but it's calories. If it's straight sugar, you produce a lot of carbon dioxide. So about 4 or 5 pieces of C's candy right before you exercise, not a good idea. Okay, because you are going to spike your CO2 levels, and you gotta get rid of it. Normal people just get rid of it. Okay, there's no restriction. Their lungs are working. Their carbon dioxide levels are maintained. Our body is amazing. Our body is amazing how it does that. Are you guys going to have lunch? Mm-hmm. We're going to have to exercise to get your lunch. Eric?
We have a question here from all the way from Chicago, Illinois, from Maggie.
Yay!
Maggie.
Oh, it's hot there.
She's asking, should I come up with an exercise plan, or should I just start doing some?
That's the plan, Maggie.
Well, I gave you the 3 things, that you need to put in there. You need to do some aerobic exercise, and that in the beginning, it's walking. Okay, friends, it's walking. It's not running. Don't go out there and try to run. Okay, highly overrated. I know, because I'm doing a lot of it right now. Okay, and you need to do some strength training. And you should do some flexibility training. And it can be as little as 5 minutes of each one of them.
Maggie's been in the planning stage for a long time.
Yeah.
God bless you, Maggie. My sister's name's Maggie.
Got another one from Chris Benson here. She's asking if we are exercising with healthier people, for example, hip hop today, what are some tips to help me keep up? Like sitting in a chair and just doing arms, or what?
That is good. Yeah.
Yeah. So, yes. Anytime you're seated, we reduce the workload. Okay? Anytime you can support yourself in any other fashion, like let's say you want to be standing. Okay, if you had actually, and this might really work in that hip hop thing, okay? If you had a cart of any kind, something where you can rest briefly to catch your breath quicker, That would take a lot of load off. Anytime you can support this way, okay? Her knows, you know, when you use a shopping cart or any kind of wheel cart, unbelievable what you can do, because you're able to stabilize the respiratory muscles and utilize them. So even if you had the cart nearby and you just were able to catch your breath this way, because it's really hard if you're in a class to go over to some area and catch your breath. But even that, you know, even briefly, can really restore you to where you can go back and continue. The other thing is, you know, in hip hop, there's upper body isolation and there's lower body isolations. And, you know, maybe you would just decide, I'm going to tell the teacher, this is what I'm doing. I'm going to be working on, you know, one or the other, and maybe not both. Okay? And, you know, half of hip hop is just looking, you know, buck. Okay? So anyway, yeah, I've done a few of those hip hop classes. I have. I'm not going to show you my move right now, but okay, that was a good question. Thanks. Any others? Keep asking the questions on the internet because they're going to have to exercise real soon if you don't. Yes?
My mother was an RT, and she forbade us to drink soda because she thought soda increases CO2.
Okay.
Is that a myth?
Okay. I don't know that it physically. You know, it's just my karaoke, you know. Okay. So I was asking that her mom usually would not let her drink soda because she thought it would increase CO2. I don't know that it actually physically can increase CO2 in the blood level. I doubt it. However, what does it do? It bloats you, and that's well known. You know, you ever see that on the exercise magazine, the Self magazine, flat stomach to 30 days? Mm-hmm. You ever see that? Well, that sucked me, and I looked at that. And one of the things they talk about, carbonated beverages, because carbonated beverages lead to bloating. Okay? Now, here's my other limited law of physics. Okay, come on, it's coming. All right, so two objects cannot occupy the same space at the same time. That's a law of physics. Okay, so if your diaphragm is supposed to seat here, like in this position, like a dome, okay, and you have bloating, it's pushing up on the diaphragm, then the diaphragm can't move down. Okay, it contracts this way. Okay, and if it's being pushed up on, it's being in a fixed position. And actually, that is part of what happens in air trapping as well. The diaphragm gets flattened out. Okay, so it could affect some people. And I've had some patients, you know, when they're really struggling and they are working very hard to breathe, there's a lot of belching going on. Has anyone experienced that?
I belch all the time.
Feels good. but part of that is that they are air swallowing. Okay, and also too, can carbonated beverages aggravate that? Yes, it can. So, you know, I can never ever err on. It's tell the moms are wrong. Okay, the moms are always right. Just know that.
I never drink soda.
The moms are always right.
Yesterday during yoga, or actually during the week, like some people express like lower back pain, including myself now. Like, how do you recommend sort of an active exercise regimen if people have chronic back pain?
Well, I'm afraid that's going to be a little out of my scope. So I really wouldn't want to necessarily comment. We get a lot of patients that do have problems with their backs. And yeah, anything that's seated is going to be easier on them. You know, that's why we use a lot of recumbent kinds of exercise, because it supports the back, it supports the upper body. It is easier to breathe. So that, you know, if you really have a lot of lower back pain, ask for a physical therapy consult, okay? And then if you're in rehab, then the rehab therapist can have that knowledge, so they make sure they're not having you do an exercise that's not good for you, okay? Or that can
help lower back pain too.
Excuse me?
Core strength. You know,
oh yeah.
Strengthening your core will.
Yeah. Yeah, and you know, I have to say, a lot of core exercises are pretty high level, and they are somewhat restricting to breathing, so you really have to breathe with some of the core exercises. We make our patients do core exercises because we are not the kinder, gentler pulmonary rehab program. You might know that there are those that exist, but the sergeant is not going to be one of those, okay, that has that. So we do a lot of things, and we do put patients in situations where it might be uncomfortable to breathe. I think, you know, there's a lot to be said about desensitization to shortness of breath and breathlessness, and the fear that is, the intense fear that is associated with not being able to get air. I don't think there's any more primal fear than that. I mean, you know, maybe the lion is not good, but not getting your air or your breath, there's nothing more. So sometimes being put in that situation and having somebody guide you to know that you can calm yourself down, get yourself into a more, in a position where you can recover, okay? So well, now you're making me do this. What are recovery positions? What are good recovery positions? Yes, that's one of them.
Child's pose.
Yes, child's pose. Yeah, I make the patients do that. Child's pose, any of this kind of pitching forward, okay? And this situation also, even this, if there's nothing around and you're going, what am I going to do now? Just even leaning against a wall with 1 foot back, one foot forward because of your back. And just leaning against the wall reduces your work of breathing. Okay, so if nothing else, that freaks people out. What if I walk out there and I don't see a bench or I don't see a chair and I can't get my air? Okay, so last time I spoke to the CFRI group, somebody called in and they wanted about surfing. I just love that. I just think about that question. And surfing's fine, I suppose. But you know what I want you guys to remember is you should be carrying with you your rescue drug. Okay? Don't leave home without it. Okay? Because you don't know where you're going to be or what the situation is, especially if you're exercising outdoors. There are things you can get in contact with. It could bother you. It could be jungle gardenia perfume. They have not taken it out of the market yet. That is a very serious thing. I'm calling the FDA all the time about that. But anyway, you could be around something, so you should have that with you, okay? On your bicycle, you should have it with you, okay? Do people do that? And some of you say, well, I just had my nebulizer treatment. I just took my Duoneb. I should be good for 4 hours. Well, it doesn't work that way in the real world, okay? Because you could have had your Duoneb, but I'm going to trust me. You got around something that really bothered you, and if I assessed you and I decided you needed another bronchodilator, you're getting it. So it's not. It doesn't work that way. That's why you need to have your arsenal with you. Okay, you've stalled enough. It's time for exercise. Okay, I'm going to have to take this over here because we're going to do this. Now, I want to give you an idea of what these unsupported arm exercises are all about, because I have to be truthful, that was really confusing for me when we got in the NET trial, because we really hadn't been doing that much of that, and now we incorporate it all the time in our rehab. It's very interesting. We have UBEs, they're called upper body ergometers. We use those a lot, and those are really good for your shoulders and what have you. But this concept, so in here in our little packet, and you don't have to worry about it because I'm going to guide you through them. We're going to do them. And these can be done in a chair. We could do these in a chair. But there's a whole list that are standing exercises. And what they have the patients do is they have them work up to doing this for 15 minutes. Whew. It's pretty awesome. So we're only going to do it for a couple of minutes. Okay? But they'll give you an idea of this upper extremity, and then we're gonna actually do some upper extremity and some lower extremity, and we're gonna do some stretches. Okay, so we can stay seated for this part. By the way, if you didn't want to do it like that, you know, you could just do punching. That's what we do in the rehab. We do every kind of punching. Uppercuts, hooks. We do it all, okay? That's what we do mostly, but there's a sort of maybe a more entertaining way of doing it. So, first one we're going to do, everyone's game for this? You're game for this? Okay, so first one is pick the cherries. You know how to do that. You got how many cherry trees? 3. 2. Okay, so and usually you do each one for about, 30 seconds.
So if you wanted to use weights,
now, on this one, what they decided they wanted the patients to do is, if they got so good, they only wanted to do a light weight, or 1 or 2 pound weights. You don't want to always use heavy weight. And I'm going to show you one exercise I want you to do, and I don't want you to use heavy weight. Okay, now punching. Kind of good to have second hand. The patients say I lose my train of thought. And that I can't count worth a darn, which is true. So believe it or not, that's not even 30 seconds, friends. Okay. Tug of war.
Maggie says she's doing this too.
Besides when she typed?
Yeah. Oh yeah.
We could do this in front of the TV.
Yeah. And God bless them, these are patients that came in, and a lot of them were using 4 liters, 5 liters. They were very sick. Drive the big truck. And I have to tell you, I don't think I've ever had patients that were more adherent than this group in the net trial. And they did everything. Everything.
The blood is draining.
Yeah. Now, if any of you guys are getting winded, just drop your arms down, rest them for a little bit, and then pick it back up with us, okay?
Was Chris doing it? You can do it.
He's doing it. He's doing it.
Total crib.
Okay.
This is driving here, so she's actually driving.
Oh, she's driving here?
Yeah, she's
Good.
driving.
Eric, we're pulling weeds now.
Oh, pulling weeds. We could do this at boot camp.
Yeah. It's fun.
These are good. You were sitting at your desk at school.
Or you can do a punching regimen. I like to do the punching regimen at the senior center. We do that, the maintenance. Flutter.
Really?
Where's Patrick?
Probably sleeping.
Yeah.
Anna, your boyfriend's so cute.
Nice t-shirt.
It's like, I get to have my CF t-shirts.
Okay, don't drop the arms. We're going right to crisscross. So that's the other thing. You notice how we don't allow a rest period. Please use a rest period if you need a rest period. Okay? Please, please. Oh, I hear some air moving.
I think there's one moving on my shoulder. This is good. This would be really hard with 2 pound weights.
Yes, that's why actually in the net they said, well, if the patient really wants to, they can use 1 or 2. Because there were a few patients that were able to. But for the most part, it was very hard. Okay? Stretch the springs.
Hit your elbows.
Done this in years.
So there's 15 of these, so we've done,
Yeah, pace yourself.
yeah, we've done 8. We're going to 9.
So you're tightening your back, right?
Yeah, on this one I am. Well, I do want to show you this one exercise. I think it's very good. Okay, stir the soup in the cauldron.
Oh, your back.
It's nice when you go up and down.
The blood flow feels better.
Okay, we'll do 2 more.
Maggie says it's killing my arms.
Keep going, keep going.
You almost there, man, you almost there. Okay, and chop the wood.
Now, do you switch sides off and on?
You can if you want. Or you could do chop wood twice.
Ooh, yeah.
Actually, when they showed me that, we had to go for training, so we made, because like I said, it had to be very standardized. and we all did it. That was the other thing we learned, that people were not very standardized in pulmonary rehab.
Yeah.
Yeah, big surprise.
Are you left-handed? No.
And last one, across the monkey bars.
I used to do this when I was little.
That's another place where I had accidental fall. You always had that tan mark underneath. I'm sure that's not allowed anymore. God knows what was in it. Okay, now, just take a deep breath. Exhale out. Take another deep breath. Exhale out. Well, we kind of blew it. We should have taken our heart rate. Taken our heart rate.
Good one, Gina.
Yeah, I know. Okay, so those are examples of unsupported arm work. And you can see how they can be quite challenging, okay? And they're gonna give you those Madonna arms. Okay? Now, so that's another thing I want, another resource for you guys, and I put it on the back of the page. I really recommend this. This is your taxpayers' money in action. So this is put out by the NIH, National Institutes of Health, and it's a free it's a free guide. It's exercise and physical activity, and it was designed, they felt, for more mature adults, but I gotta tell you, if you've been ill or you're trying to get into exercise or what have you, there is just not one exercise in it that's not good for you. This is again, a panel of experts looked at this and decided what to include. And they have wonderful pictures, and they kind of give you options of either being seated or standing to do them. And a lot of the ones that are in the book are the ones we use in pulmonary rehab. Not all of them, but a lot of them. They have an excellent part in here on balance.
I need that.
And balance is actually another part that I didn't really talk to you about, but we know that a lot of people don't, especially patients that are, well, post-transplant, I think a lot of you realize how poor your balance was. So, and balance, is a function of your quadriceps, your proprioceptor muscle, your eyes, your ears, okay? And then also you're on a lot of drugs and what have you. So balance is very important.
Your feet muscles, right?
Yeah, your ankle muscles.
That's nice.
Yeah, all of those. And they have some really wonderful exercise. And this is free. You just get on the website, and I gave you the catalog number, and they'll send it to you. Okay? And we use this in the rehab. We give all of our patients one of these.
I didn't get one.
I don't have enough here.
No, I in rehab.
Well, probably we didn't give the transplant patients that we gave you that little booklet. And the reason why is because we can't trust you. If I gave you this book, you'd be doing them, okay? And you weren't supposed to be doing them yet. End of discussion. Okay. So let's do some of the stretches. Although there are two strength exercises, I want to make sure I get this in. Couple ones, people are talking about these muscles here that you get, because if you have a lot of problems with breathing, you're more like this. You guys ever notice how you get like that? Okay, and that's probably because you're stabilizing these muscles to help you to breathe. So what we want to do is we want to try to open. Okay, so one of the exercises we do is, it's very easy. You do this several times a day. Is you just take your elbows. First of all, drop your shoulders. Take your elbows and you push them, you want them to kiss each other. The elbows have to kiss each other. It ain't gonna happen. It ain't gonna happen, Anna. And you hold it. You hold it for, you're working up to like, holding it for, 30 seconds, but you hold it for 10 or 15. If you're feeling it a lot, only hold it for 5 seconds in the beginning. When I first started doing this, my little rhomboids would just go into spasm back there. These are very small muscles back here. Okay?
Well, partly I can't. I'm stuck.
Okay, you're not going to be able to make it there, okay? You're very flexible. Okay, another one you could do. Didn't you say you were 20?
Yeah. But I've done a lot of karate and yoga, so.
Oh, okay. Another one you can do for those small muscles only a small weight, okay? The weights are here. And you want a chair without arms, guys, okay? And so pulling back, pulling back. Okay, and then the second one is seated flat. No weight on this one in the beginning. You thank me later. So you keep yourself down. Now can these be done seated? Can these be done standing? Yes, you can do. The way we do our rows usually is either on a bench.
Oh, yeah.
Or the other way to do them is laying down.
You have to be careful with transplant. I popped a wire doing that, so.
How long?
Well, it was on a weight
A
machine.
year and a half? Oh, that wasn't. Wow, that's unusual. I mean, did they tell you why they thought that happened? Because.
No, I just went in and said, I feel something weird. And she said, oh, that's just your wire. Don't do that again. So.
Oh, nice. Oh, okay. Well, that's interesting because usually it should be healed.
That's what I thought too.
Yeah, it should be healed. All right, and then let's see. What was the other one I wanted to show you? Oh, and then the old one where you go, you're in a corner. This is like a corner, and you come in to stretch in. That's another one you can do. But I like this one. I like the kissing one because you can be anywhere to do that one. And it really helps to lift up. You're lifting up this part of the rib cage. Okay? Whether you know it or not, you have to.
But you don't want to arch your lower back.
No, you don't arch don't arch your lower back. You're just pushing these two together. So it's not that, okay? It's this. Do you see the difference between that and this? On me, you should be able to tell. There's nothing there. All right. All right, so, yes?
I do have a question. I get a lot of shoulder tightness up here, and I was wondering what is a good stretch to relieve that?
Well, okay.
And sometimes my neck gets kinked because it's just so much.
Oh, yeah. Breathing. Let's do the stretches now. Let me take you through some of the stretches. We'll do some of the ones in the booklet there. All right? So you guys you might need to stand, or maybe not, depending upon where you are. But let's go ahead and do some of those. And these are all here for you. Okay. So the very first one is just, believe it or not, going over the side. Okay, and you hold it. Okay. Now, if you want more intensity of stretch, believe it or not, take your hand down, flex it. You'll feel it more automatically. I can see how it is. Okay. And last but not leastly, take your hand and you're very careful. Because I got a bad neck. And you just let the weight of the hand be there. Don't yank on your neck. You won't get more out of it. And really, it's holding the stretch that really does it for you. And they wanted these poor patients to hold the stretch for 30 seconds. I was just excruciating. Are you done yet? Are you done yet? It's just like, okay. And then relax. And then we'll go the other side. Start here. Start here. Okay, and then take the hand, push down, flex the foot hand. You really feel it then. Okay. And then lightly. Oh, this side. It's cranky. Okay. And then side to side. These are range of motion exercises. Everybody should be doing them. I'm lucky that my job I get to do them. Because I wonder if I'd do them if I didn't have to. Okay. And then we're gonna do what we call shoulder rolls. Up and back. And I call this the poor man's massage. And then we'll go the other way. Don't you be popping any wires on me. Yeah. Oh no. Oh no, no, no. Absolutely not. Okay, now I'll show you my favorite. Okay, I'm going to clasp the hands, I'm going to turn them out, I'm going to take a breath of air in, I'm going to look up, and then we're going to exhale out and we're going to round our upper back. Right there is the spot, right? And then breathe in. Exhale out. Do a couple of rounds of those. Okay, and we'll come back down. And another one to get this shoulder area. Take your arm out. Take your left hand, put it on your right. Cross over. Okay, but now, I don't want your shoulder, drop it down. Get the shoulder blade in the pocket. Very flexible shoulders. She's wrestling. Very flexible. Oh, there you go. That would do it. And then we'll do the other side. Crossing over. Make sure your shoulder is down. The shoulder blade is in the pocket. You guys know what I mean by in the pocket back there? No. Okay. So instead of winging out, it's in. And you bring it down into the pocket. That stabilizes the shoulder.
Oops.
Yeah, I was made for this. Okay. And then another one that's actually good to open up the lower ribs. But we need to do it right now. I want you to give yourself those shoulders apart. Okay. So I'll demonstrate one. It's called a trunk twist. So you breathe in and you exhale out, but you have to bring the back heel up. Okay? You don't do this. That is really bad for your lower back. Okay? So you're going to breathe in, you're going to exhale out, and you follow your hands to your eyes, and the back heel comes up. And then you come the other way. This is the way you do a trunk stretch. Very good. Okay, because you can feel how you've opened up these low ribs this way. Okay? Very good. Okay. Now let's see, what else can we do here? Oh, there's another one. Clasp behind. These are all on your little booklets, okay? Clasp behind. You're going to lift up, open up, take a breath, exhale out, and drop your shoulder down. And you're going to open up the side ribs. And when I do this, I make sure I exhale out when I go to the side. It makes sense, doesn't it? Okay. But then I like to really expand this side and open up those ribs.
I have a question. I have a lot of scar tissue from a surgery right here. Is there stretching exercises to alleviate the pain?
If you have adhesion, they say they just break down when they break down, unfortunately, because they can really zing.
Oh, it's painful.
Yeah. Breathe in, exhale out. Yeah, there's not really any, And then relax. Okay.
We have about 5 or 10
5 more?
minutes.
Okay, then, should we move on to just a couple of strengthening exercises, or you want to finish stretching? We can do either one. Stretching? Okay, good. I love stretching. Okay, so another, hold on to something, because we're going to stretch our legs out here. Okay, so we do a quadricep stretch. Okay, so either your foot or your pant leg, whatever's available to you. I knew she was going to do it. All right, so just push your hand away from your foot, or your foot into the hand. Okay.
Sometimes when I do this, I don't feel the stretch at all. Is there a way to make it feel like
more intense? Lift up.
Back?
Yeah, like
Or to put your pelvis forward.
Yes.
Try and move your leg back.
More?
Back more.
Oh.
Also, I learned something in my yoga class.
Exactly, because this is dancer's position. Okay.
Try and pull it back like that.
It's a good balance work too.
Yeah. It's like Warrior 3 kind of. Lean forward.
Yeah, and Warrior 3. This is a perfect transition for Warrior 3 if you want to do Warrior 3, which is this way. Okay. All right. Do the other side. Same deal. And you are very flexible. You be always careful. Even when you're very flexible, you can overextend. Okay. Now the hamstring stretch, to do it standing is really difficult. So you basically need to get up, down on the ground, you really do. Or the way we did it in the classes, we had like a little bench and we had them put their leg up to do it, okay? You really don't get the full range of motion by just flexing and going over. You'll feel a little bit. Some of our patients feel quite a bit. I mean, you can stretch the hamstring that way, but it's really better, and I have it in the booklets, to be, laying down, or on the ground, and or on a bed. You can put one foot over and one foot out, okay? To do the hamstring stretch, just like that. I don't have a bench to really demonstrate, but I guess I get on the ground, couldn't I? So we basically do this one, this way, and you should feel it quite intensely there. And on this one, I say you should just settle in, because you really want to keep it long. And also make sure your foot is flexed there in a good position. This is a different stretch. You're going to stretch this part. Okay, so then you would do the other side. And then a calf stretch, would be, I'm sorry. I thought you guys might be getting hungry.
It's always easy.
That was a good question you had, but one of the things they feel that leads to a lot of low back pain are tight hamstrings. So really stretching your hamstrings out can help with low back pain. And I have to do that to myself because my hamstrings are very tight. I have this one little gal, Alicia. She puts her little head right there. The patients always remind me, "Oh, Alicia, she's putting her head down again, Gina." Okay, Alicia. I'm up here struggling. And when you're in this position, okay, this is not the best position to breathe because we've shoved our gut up against our diaphragm. But just continue to try to take a long inhalation and exhalation. Okay. Most of this is that people are trying to hold their breath when they're stretching. You do not hold your breath when you stretch. You're continuing to breathe in and out. Okay. Okay. So then the calf stretch. It'll just be one foot forward, one foot back, and leaning in. And this is another one where you're very flexible. You're not going to feel it as much. Okay. So this is where I am flexible. So for me to feel a really good calf stretch, I usually need to do it on a stick. So you just hang off one side. Yeah. And that's how I usually do that because that's where I am flexible. So there's a couple ways to do it. And then when you're doing the calf stretch, okay, I want your toes inward. There you go. Very good. Very good. Yeah. So you don't want them flaring out. That's a different stretch. Okay. Perfect. 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 Maggie, you looking good? She's still doing it. She's having lunch. Well, what time is it there in Chicago? Probably 4 o'clock. Oh, you know, 2 o'clock. All right. Okay. All right. So. It sounds like all of you are doing some exercise. You all look really good to me. But the main thing is when you are. By the way, too, if you one thing I don't want when I don't want you exercising, you have a fever, you don't exercise. Okay. You don't. Okay. And also, if if you're feeling very nauseated, I really would not want you exercising. Okay, because there's too much danger of you vomiting and aspirating. Okay, it's not a good idea. Your body's telling you it's not capable of exercising right now. So there are going to be times when you really cannot do too much, and that's just going to be the way it is. But you keep into your guidelines and keep doing what you're doing because it's the most important thing. It makes you feel better. I think it makes you feel better.
I have a question. Yeah. On behalf of maybe some other people that have really, really compromised lungs, I just sort of heard this word of mouth of like, it's bad for you to like put your head below your heart or to lay on your chest? Is that it makes it harder to breathe, obviously.
It makes it harder to breathe. I mean, there are some situations where you'd have to be pretty compromised. I mean, there have to be a fair amount of heart disease for us to be concerned about that. But there is, there are patients that have also, pulmonary hypertension. And even now, it's interesting, even in pulmonary hypertension, they're beginning to exercise these patients where we just thought, oh my God, they will drop dead. So there's some small studies and some physicians that are now recommending, that Stanford has an actual clinic, a pulmonary hypertension clinic, where they're seeing patients that are either have primary, means usually it's a genetic kind of situation, or secondary pulmonary hypertension, which is elevated pressures within the lungs and in the vascular system. So even those patients are now being given some kinds of guidelines to exercise with. Very interesting, and they do say that they improve. Yeah, those are the ones that those are the ones that give me gray hairs. Okay, then they have pulmonary hypertension because that is one of the diagnoses they transplant for.
Yep.
And like I said, we just thought, oh, don't exercise Susie. But now we're exercising Susie, and Susie's doing just fine. That's great. Yeah. Okay, well, I thank you because it sounds like the chow's on.
We really want to thank you very much for coming.
Thank you. Oh, I like that. I like that. And I like this color too.
You're one of us.
Yes. Thank you very much.
Thank you so much for coming.
You had wonderful questions, and I'm going to leave a few brochures about pulmonary rehab. And like I said, I think that in some ways CF was sort of passed over a little bit in the rehab scheme, to where people were not even told about it. People had poor information about it. And you really are a patient population that would be well served by pulmonary rehab. So I think maybe part of that is, let's just face it, people live a lot longer with CF than when I first started.
Can you tell them about the lung games? It's still happening?
Yeah. Well, our national lung games are kind of not happening because we kind of lost our sponsor. And unfortunately, the insurance part of it is terrible. And so we're still having some northern lung games. They're going to be in Concord. And what we do is they take all of our patients come, and pacing is very important in rehab. Not that you can't do it, we want you to do it. We want you to do it smartly and pacing. So what we do is we go there and we have these different events. So we have like the new step, we have a 6-minute walk. 6-minute walk. We have cycling. We have ping pong. We have basketball. We have shuffleboard. All these kind of different things. But a lot of them are predicted events. So what happens is you train and you predict how long it will take you to do whatever the task is, which is like on the cycle, on the airdyne. I'm going to do 1 mile, and it's going to take me 4 minutes and 20 seconds. And then we move all the clocks in the whole gym. No one has watches on. No one has any clocks except for the timers. And whoever comes closest to what they do wins. So you can have someone who is 15 competing against someone who is 85. Because pacing is everything. So you have to know your body and what you're able to do. I mean, if you want to go full out, you can go full out, but you better make your mark. Because that 85-year-old knows exactly how long they gotta go. So anyway, those are a lot of fun, and we took 2 teams. We've done the national ones. We've gone to Chicago. That was one of our places. We're actually in Naperville to do the games there. A very nice facility there. They have a beautiful pool there. And then another time we went to Georgia, and got a little Southern hospitality. Okay, that was a trip. We ended up being in a dry county, and we had to drive those patients afterwards to find a nice little cocktail. I didn't even know. I go, this is a dry county? Yes, ma'am. Oh. So we loaded them up in the bus, we got to the next county. Because they said we were celebrating that night. But it's a lot of fun, and we had some transplant patients that went with us. Some of our transplant patients, actually. One of them went with us, and also from the other teams that they did go. So a lot of fun, and that's the other thing I would encourage, obviously the transplant patients can participate in the transplant games. But that's a good way to do it is if the CF organization wanted to do something like that, it's easy. And that's how you even the playing field. Is by, some of these things are skills. I mean, basketball, throw, and ping pong, you got to be good at it or you're not good at it. But other these things you can time. The most difficult one for sure is a 6-minute walk test. It's really hard to be able to predict that you're going to be able to walk each and every time. Really hard, really hard. And one of our participants, God bless her, Jamie, when we went to Chicago, she won third. It was really wonderful for her. It was a great day. We had a great time. Great time.
So just one final question for the web audience. Like, if they live in Georgia or if they live in, Iowa, like, how do they find a rehab program?
Oh, thank you. You can get on the web. There's 2 places that organizations that most of you will list their pulmonary rehab programs. That'll be, it's called the AACVPR, American Association for Cardiac and Pulmonary Rehab. And a lot of us will list, but not all programs will list. It costs a lot of money to list. So you can call, I would call actually, or get on the website to the hospital. All hospitals have them now. And look for pulmonary rehab, or look under wellness, and see if they have a cardiac rehab. Sometimes it's a rural area, they may only have a cardiac rehab program. A lot of cardiac rehab programs will accept pulmonary patients, and want to accept pulmonary patients, because maybe they just don't have enough to feed it, but they would like to include them, because it is different. It's not exactly the same thing. So those are 2 places. In California, you want to get on California Society for Pulmonary Rehab, a CSPR, almost all this list in that one. And you could always, you could call them and say, would you know, is there one, so place. A lot of us will know about other programs that are starting up, or if one closed. So those are all options. And there's other things in pulmonary besides exercise. There's a lot of, education, breathing retraining, making sure you're taking your medications correctly, technique-wise. Because believe it or not, technique-wise, it's changed just from when we went from the CFCs to the new propellant. Has anyone experienced that? They know the difference? They can tell the difference in their inhaler? It's different. Well, you don't have to do it anymore, God bless you. But there was a lot of learning pattern to that, because the CFCs were totally different than what we use now and how they operate. And there are things that change.
Someone's asking if it's covered by insurance.
Oh, great question. Okay, it is a Medicare covered service nationally. So if you have already got Medicare, because some of you have, then it would be a covered service. It is in San Mateo County, Health Plan of San Mateo will look at it individually. So if you're Medi-Cal, they will look at it individually. A lot of PPOs do cover this service. Now look at Medicare. Does Medicare cover it? Yeah, okay. However, I have to tell you, it's not really good. This is something for, I mentioned this to CFRI, that right now it looks like GHPP does not cover it. Because in general, all the Medi-Cal insurances don't cover it. But Health Plan of San Mateo has opted to look at it. So that's a real problem, because here is a Medicare covered service that Medi-Cal has chosen to deny. Okay? And the reason why I know this is because recently we had a patient and we tried to run through the system and they said there's just no code for it, and because there's no code for it, it doesn't exist. And you know how strapped they are right now, if you're trying to deal with them. I mean, what, there's one person for the state or something? I don't know how bad it is. It's not good. My experience was not a great experience in trying to get this covered for this patient. And in the end, it turned out to be a denial.
And how sick do you have to be to go?
That's a good question. Under Medicare, if it is a diagnosis of COPD, there are guidelines, and they look at pulmonary function.
I don't think there's any necessarily guideline under necessarily for CF. I think a lot of it has to do with whether or not your functionality and what you're able to do, or if you're having a lot of exacerbations. If you're repeatedly coming into the hospital, that in itself is causing you to decline. We all know that. So that might be a reason to institute that right away. And we have had some older CF patients in our group that have come and that are not contemplating transplant. However, if you are contemplating transplant, I would definitely think about participating in the rehab program before, especially if you hadn't had any exposure at all. You're going to get sent to rehab after. That in itself is a reason to go.
Well, I'm sure the cafeteria is going to be angry at us.
Yeah.
But I
just
hope
one
you
more
can
quick
join us.
question.
Oh, one more quick-
Is this material available online?
No.
No, okay.
Maybe the person can email us or Jessica or you or whoever is the contact, and we can find a way to get it.
Okay.
We're perfectly happy to scan it and deliver it to anybody you want.
Right, right.
Perfect.
That's great materials. Well, thank you, Gina. Thank you.
I've been doing one meeting.
Oh, you have stuff too?
Yeah. Those are great handouts.